Good morning, everybody. Can we slow down this music part when we just decrease the volume? Okay, yeah, that's. So I'm Dr. Amit Patil, and I'm not a master. Actually, I'm presenting before my master's here. So, anyways, I'm presenting DIEP flap for a 35-year-old female who has received NACT but partial response. So, she is going to have more modified radical mastectomy with a larger skin loss, and uh, so I'll start with the presentation so that I'll rush up a little faster video and give you all the steps. So this is 35-year-old female with this is mammography preoperative imaging done, CT angiography have been done. Periumbilical perforators are located not just for the location but also its course through the rectus muscle. So this is the modified radical mastectomy being performed. So we just have to observe the defect basically. So the skin flap is very thin, that's we need to see so that the edge do not get necrose at the end. So we all see the recipient vessels. So that there is thoracodorsal on the axillary side and internal mammary artery on for the as a donor recipient vessel. Let's start with the flap marking. First we mark the iliac bones. The midline is marked. It is a very critical step marking the midline so that we do not both the ends coherent with each other while closure. So the upper marking, the lower marking, it has to close primarily. We do Doppler for perforators, but generally, and these are the rectus muscle, but generally the perforators are located around periumbilical area. So CT angiography not only helps us locating, but also helps us the locating the entire course of the perforators into the muscle. We also do ICG. Okay, the illumination is basically the previous marking of our perforators. We just get illuminated. The adrenaline infiltration. First, we isolate the superficial inferior epigastric vein, which could be a draining vein in 5%, major draining vein in 5% of the patients. So we preserve it. Then we start harvesting from lateral side, raising over the rectus fascia. Start identifying perforators in the periumbilical area. So there are multiple perforators down here. We start harvesting from the opposite side. So ICG can be utilized to see the perforator course through the rectus muscle if one wants to know the course. So this is the perforator and its course through the rectus muscle. So a cuff of rectus fascia is taken, but nowadays we also have started dissecting around the perforator and even preserving this cuff of rectus fascia. We trace the perforators. So this is the second perforator. We trace the perforator through the rectus muscle after cutting the rectus fascia. This is the third perforator. So now we are cutting through the rectus fascia, anterior rectus fascia. We're dissecting the perforator through the rectus muscle. This is the first, second, and third perforator, and the intramuscular course of the DIEP vessel through its origin. So we are preserving the rectus muscle along with its nerve supplying from lateral side. We have used ICG dye to check the perfusion of the flap. Basically, we just want to exclude the devascularized zone 4. So these are the two perforators through which the flap is being perfused. So this is how the illumination fluorescence is seen in the ICG dye. Zone 4 can be marked out, but in this particular case we need the entire flap. So that's why we took the second DIEP vessel also. So this is the zone 4 marking. So one can use and exercise this part. Now the donor area rectus, this is the rectus muscle, the rectus fascia, the nerves which are supplied rectus muscle from the lateral side. We raise the upper flap, neo-umbilical positioning is done, rectus muscle is closed, rectus fascia are closed primarily, no need for any mesh, primary closure. So this is how the closure is. Now this is the defect. Once the flap is being harvested, try to weigh the flap. These are the DIEP vessels on both sides, since we are using zone 4. Now in the recipient area, we cut the pectoralis major muscle. Now the perichondrium is being dissected. At costochondral junction, we excise the cartilage. This is the internal mammary artery and vein seen through the microscope. So we do vein first and then the artery. The major problem has been the thin walled vein which can kink. So generally its lie has to be kept properly. So this is one side. The distal cut end of the internal mammary artery and vein is being used to anastomose the second part. Now another major critical part is the flap molding. So the main aim has been superior pole fullness. So we do the coning so that the projection, we can get the projection, and we suture it back. So we will see the lie of the vessels or both the pedicles. After this step, what we do is the we mark the upper edge of the flap, we deepithelize it and we place it below the upper flap for superior pole fullness. So this is the deepitheliation done. Good perfusion, we can see the good perfusion in the entire flap. One or two stay sutures just to place, but we just keep suturing to minimal, and then we suture skin. So generally patient stays for 4 to 5 days in hospital in post-op propped up position. No anticoagulation, abdominal binder is useful. So these are some of the results. It can be used for post-mastectomy defects. Nipple graft can be used as a deepitheliation. There are certain losses which can happen, acute and complete flap loss and partial flap loss, which can be needs to be corrected. Breast deformity can also be corrected with DIEP flaps as a delayed reconstruction. Thank you.